Picture a woman in her 50s in rural Nepal. She's been coughing and running out of breath for years. She thinks it's just age or the smoke from her cooking fire, and her family tells her the same. However, what she actually has is a serious lung condition, chronic obstructive pulmonary disease, or COPD. And odds are nobody will ever even tell her this. This isn't even a rare story, it's a very common one. In poorer countries, up to 9 out of 10 people have COPD and are never diagnosed. The thing is, this condition isn't even small. It's the third largest cause of death worldwide, and about 90% of these deaths are in exactly these lower income countries. Worst part, we already know how to catch it. You ask people a brief list of questions, find out who's most at risk, and send those people for a proper diagnostic test. It's cheap and it works. But there's a little catch. Almost every one of these questionnaires was built and tested in rich countries. And a questionnaire is basically tuned to the place where it was made. If you move it somewhere else, the tuning's off. It starts missing people. And almost every study admits this in the limitation section. But none of them have fixed it. And that's what our project does. We built a questionnaire designed to keep working when it moves between countries. And we're not just leaving it in a computer, we're taking it to a real NGO in Nepal, the Healthcare Association of Nepal, in a program of around 4 to 5,000 people. Manraj will show you how well it does and what we're planning on doing further.
So, how do you actually build a test that transports between countries? We trained it in one country and tested it in another. Completely cold. We kept only the things that mean the disease itself. So, it never really learns anything localized. And we kept it spoken questions with no equipment, plus an optional $2 peak flow test where it's available. Peak flow basically tests how much maximum speed of exhalation you can reach when you're pushing out air with max effort. And here's how we built and tested it. We got three public datasets, one from Indonesia for testing, and two from the US that also carry real spirometry. So we can check the tool against the actual disease. The thing that matters is if we leave a whole dataset out and transport fully cold training on Indonesia and testing on the US, a population the model never saw. And this is what a health worker actually does. They ask a short list of questions, and each answer adds points: age, smoking, asthma, V's, all that stuff. And then, if they have a peak flow test, the person blows into it, and a low reading gets a couple more points. The total decides who gets referred for the test, and the cutoff is set to whatever the local clinic can handle. As for the result, trained on Indonesia and tested cold on the US, it reached an ROC of about 0.79. And to be fair and not undersell it, the best known tools, the CDQ, the LFQ, and Puma, only reach 0.65 to 0.78 once they're actually tested in the real world. So ours matched or beat the best of that, and it did that in a country it had never seen. And here's why it transports. When you train one of these, it can lean on things that predict the disease in one place, but doesn't mean disease anywhere else, which especially depends on socioeconomic factors and the body size of that person. We removed those and kept only what means the same things everywhere. And a normal peak flow is set per country and per sex. So a peak flow test means the same in Nepal as it does in the US. But there are a few limitations. It's only one country pair so far. It's trained on a proxy because the real disease labels exist only in the US data. And the biomass exposure is probably underrated. And the smoking weights are our own judgment calls. We also had to set aside the WHO SAGE data because its spirometry was way too low quality to trust. And co-training on the US disease scores higher, but it wouldn't transport. And it might not hold up in a real clinic, and that's exactly what the pilot is for. Which brings me to the final slide. We've partnered with the Healthcare Association of Nepal to run it with 4 to 5,000 people. That answers what the data can't. Can a health worker run it? Is the referral load manageable? And are the flagged people actually sick? And it also gives us more evidence to take to programs like Respire, Multipulm, and a list of transportable variables for further research. Thank you. And tying all this back together, we make a questionnaire travel, actually check if it travels well through our pilot with HCAN, and then push it for further real world impact and academic coverage. All for one purpose: to prevent COPD cases from getting underdiagnosed, where the burden is the most severe. Thank you.